Bismillah ar-Rahman ar-Rahim. In this presentation, I will discuss the Pyrexia of unknown origin. Mainly, I will talk about the definition, the possible causes, and how to diagnose and to manage a patient with a Pyrexia of unknown origin. At the end, I will summarize the most important points that you should keep it in your mind about Pyrexia of unknown origin. Let's start with the definition. There are three points that must be present in order to label a patient as having Pyrexia of unknown origin. First, the fever should higher than 38.3 degree Celsius or 101 degree Fahrenheit on at least 3 occasions. Second, the duration of fever should last at least for 3 weeks. Third, the diagnosis remains uncertain after the history-taking physical examination and following the first-line investigations, including the complete blood count and the inflammatory markers. Okay, let's talk about the possible causes of Pyrexia of unknown origin. As you can see, 20 to 40% of all cases are having infectious causes, like brucellosis, tuberculosis, pyogenic abscesses, and infective endocarditis. And approximately 10 to 30% of all cases having a malignant causes, for example, lymphoma, leukemia, renal cellular or hepatocellular carcinoma. And vasculititis are account for 15 to 20%, like a rheumatoid arthritis and genital arthritis. Okay, other than these causes, drug fever, thyrotoxicosis, inflammatory bowel disease, sarcoidosis, and familial Mediterranean fever are account for 10 to 25%. And lastly, there is a 5 to 25% of all cases remain undiagnosed. Okay. Now let's talk about how to approach a patient with Pyrexia of unknown origin. The most important step in diagnostic workup is the search for potentially diagnostic clues, which means that any localizing symptoms or signs or any abnormalities that potentially pointing toward a specific diagnosis and helping us in order the further investigations. And we can search about these potentially diagnostic clues by doing the 6 steps. The first one is taking a detailed history from the patient, including the personal data, the chief complaint, and the history of a presenting illness, asking about the duration, the pattern of the fever, the associated symptoms, then asking about the past medical history in order to exclude any immunocompromised states like HIV or any immunodeficiency disease or organ transplant, then asking about the drug history, focusing more on immunosuppressant agent and corticosteroid, or there is any toxin ingestion in the last period. Finally, asking about the family and the social history, if there is any family members having the similar condition, or if there is a recent travel history or animal exposure. The next step is doing the physical examination. All systems should be examined. And after moving to the third step, which is the laboratory test, we should ask the patient to stop the antibiotics and the glucocorticoids, as they can mask the underlying cause and make the diagnosis much difficult. Okay, after asking the patient to stop it, then we can, like after 1 week, then we can start the lab test. The usual lab test. the complete blood count. In complete blood count, we can ask the differentials for the WBC if we have a suspicion of infectious cause, to differentiate between the different infectious causes like a viral or bacterial or parasite. Then we ask for the inflammatory markers, which is the erythrocyte sedimentation rate, the C-reactive protein and lactate dehydrogenase, which usually rise if there is an inflammatory process in the body. We can ask for the blood culture, blood chemistry, which measures the chemicals that in the body, hormones, proteins, and lipid enzymes. It's used to assess a certain body organs function like a kidney and a liver. We can order urinalysis. Finally, we can order serological tests to measure the antibodies in the blood, which may be directed against the self-antigen in case of autoimmune disease like rheumatoid arthritis or SLE, or it can be directed against a foreign antigen like an infectious causes. Then moving toward the next step, which is the images. In the images, we're starting with the low-cost images, which is the X-rays, the ultrasonography. Then depending on our patient case, we can move to the CT scan, the MRI, the echocardiography if we suspected the patient as having a cardiac problem. The last choice for us is the biopsy. There are 3 types of biopsy: bone marrow biopsy, lymph node biopsy, and specific organs biopsy. اوكي هذا بس حطيته علشان يوضح لكم الفكرة عن الابروتش ككل. أول شيء اللي هو لازم 3 things اللي ذكرناها في definition should be met. لازم كلها تتحقق في البيشنت. بعدين نروح ناخذ الهيستوري ونسوي physical examination. بعدين نروح نطلب من البيشنت to stop any antibiotics or glucocorticoids that the patient takes. تمام. بعدين we order investigations إذا كان عندنا cause أو usual investigations إذا ما كان عندنا cause. تمام. بعدين طبعا لازم إحنا من البداية أصلا نسوي exclusion للmanipulation of the with thermometer. تمام. بعدين في بعض doctors order this step اللي هي ask the patient to stop or replace any medication to exclude the drug. Okay. بعد هذه ال3 أشياء اللي سويناها ممكن رابعة مع اللي هنا. إذا كان عندنا in our mind مثلا potential diagnostic clues، تمام، نسوي further نسوي بعد diagnostic tests depending لل differential diagnosis that we have. إذا ما كان عندنا وسويناها وطلعنا ما طلعنا diagnosis، okay، ما كانت results positive in أي diagnosis that we have our differential diagnosis، أو من البداية أصلا ما كان عندنا potential diagnostic clues، خلاص نروح للadvanced tests and images. okay. إذا سوينا هذه الadvanced tests والimages، تمام، طلع لنا في abnormality، نسوي confirmation من خلال البيوبسي والكالتشر. إذا still والله ما عندنا للحين والله ما توصلنا للdiagnosis أو كانت results normal، فنروح نسوي repetition للhistory وللphysical examination وللpotential diagnostic driven invasive testing. تمام. إذا still ما عندنا diagnosis نروح we order chest and abdominal CT scan. إذا كان عندنا patient 55 years or more ممكن إحنا we order temporal artery biopsy علشان to exclude temporal arteritis. Okay. If we have no diagnosis خلاص هنا يعني يعتمد على حالة البيشنت. إذا هو stable خلاص نسوي له follow up عشان والله نشوف في any signs, any symptoms, any abnormality طلعت جديدة. ممكن إذا يحتاج نعطيه الأنسيت. إذا والله حالة البيشنت deteriorating نخليه في الهوسبيتال ونسوي further diagnostic test. وممكن consider therapeutic trial اللي هو راح discuss it in the next slide. الحين نتكلم عن management أو treatment. أول step عندنا اللي هي ال general considerations اللي هي you should keep it in your mind. First, avoid empirical therapeutic trials at the beginning. Second, either you found the cause, treat the cause specifically. Third, if the patient is deteriorating and he needs a medication, you can give it one of these medications. Antibiotics هذه من البداية ممكن هي safe ممكن تعطيه antibiotics. empirical antibiotics تعطيه لو كان عنده neutropenia أو هو hemodynamically unstable. فممكن هذه good indication عشان نعطيه empirical antibiotics like infective endocarditis ممكن نعطيه gentamicin. anti-tuberculosis therapy هذه مثلا لو جاينا البيشنت من country فيها tuberculosis epidemic أو كان عنده recent contact مع patient في tuberculosis ممكن من البداية نسوي له tuberculosis skin test. فلو كان positive نبدأ له anti-tuberculosis drug like rifampicin. third option اللي عندنا اللي هو NSAIDs والglucocorticoid. هذه you should يعني never start it at the beginning لأنها mask the fever وmask the underlying cause. لكنها supportive لما احنا نسوي extensive diagnosis test ولا نتوصل لشيء. الإكزامبلز عندنا الأسبرين والأبوبروفين for NSAIDs والديكساميثازون والهيدروكورتيزون for glucocorticoids. لكن you should يعني keep it in your mind that the serious side effects that they have. بعدين عندنا anakinra اللي هو recently discovered. It's a recombinant form of naturally occurring interleukin-1 receptor antagonist. هو block الactivity للinterleukin 1 alpha and 1 beta اللي هي المسؤولة عن raising the temperature. فلما نسوي له blockage هيصير فيه subside للفيبر. وفي a list of chronic inflammatory disorder in which the anakinra is highly effective. Some doctors consider the anakinra superior to the glucocorticoids as it has lesser side effects in comparing with the glucocorticoids. Okay, at the end, fever of unknown origin defined as a fever higher than 38.3 degrees on several occasions lasting for at least 3 weeks without an established etiology after doing the intensive evaluation and diagnostic tests. There are 3 general categories for the illnesses that account for the majority of fever of unknown origin اللي هي infections والmalignancy والsystemic rheumatoid diseases. The most important aspect of the evaluation مع patient اللي فيه fever of unknown origin take a detailed history from a detailed physical examination, reassess the patient frequently. Okay, at this point you should keep it in your mind. The diagnostic evaluation may fail to identify an etiology in as many as 30 to 50% of patients, or most adults who remain undiagnosed عندهم good prognosis. Okay, these are my references. Thank you for your listening. I hope it was useful.